person? Raise your hand. Right, okay. For this lecture, just think about this question, then you listen to the lecture and go back and see whether you can write an essay in 20 minutes. Discuss the relationship between PID and SDI. Go back and listen to this lecture and go back and see whether you can write the essay in 20 minutes listening to what I'm going to say for the next half an hour or so. I hope I can finish it here. I'm going to just slightly introduce the lecture content and look at the epidemiology and global pattern and see the pathogens related to STD and what now we call STI and how it developed into PID, looking at the pathogenesis, some clinical presentation, and just a little bit of testing of the STI, principle of management, and just to again review some of the important pathogens for you to understand and conclude from that. You know that when you talk about pelvic inflammatory disease, it's an upper genital tract infection, but it will be triggered by a lower genital tract. It begins from a lower genital tract infection because you know that all the pathogen does not ascend into the uterus unless there's some triggering factors. So many of these pathogens or sexually transmitted infection has a link to PID, and that's very important in terms of it becomes a clinical problem and also a public health issue. And you think about it, it's a continuum. So you get an infection in the lower genital tract. If it is treated, nothing will happen to it. But if it is not treated or unrecognized, then it ascends, causing cervicitis, compromising the canal, and ascending into the intrauterine cavity, tubes, and outside. Then becomes a pelvic inflammatory disease. So it always starts. It's a continuum. So at the end of it, in severe PID, you get tubular ovarian abscess. Most of you have seen during your training days or whenever you work, wherever you are. So it is very important to understand the role of STI to link to this PID because it's not independent. And to prevent the sequelae of PID, you need to identify the STI and treat them early, and that's very important. Don't worry about copying. I've left the slide. You can get the slide from the organizer. Now, historically, sexually transmitted disease, as it used to be called, has been there for many, many years, more than 400 years. It's usually called, it initially called sexually transmitted disease, but now it's called somewhere in 2000. She started in 2000, by 2010, most people call it sexually transmitted infection because the pathogen caused infection, not yet a disease. So if you call it sexually transmitted disease, then there is a different connotation to it. So when you think about all these STI-related infections, most of them they are bacterial, but because of antibiotics, they're much lower in prevalence. But nowadays, in the 21st century, the viral STI has increased. So when you look at it worldwide, it's a global problem. It's not only, but it is a global problem. It also occurs in our country. So if you look at non-HIV STI, right now HIV management is so good. So they are now becoming quite lower in prevalence. And if you look at non-HIV STI, WHO reported in 2019 an increase of new cases of especially chlamydia, and that's very important, chlamydia, because chlamydia causes fertility and also causes PID. And also trichomoniasis, because trichomoniasis and chlamydia are the two most important STI infections. But when you think about it, these two are bacterial, so it's easily being treated. But why does it still cause a problem? Because a lot of the infections are under-recognized. They are asymptomatic. So the other things that also arising around the world in the viral is in terms of genital herpes and also HPV infection. So what are the STI that's very important in PID? So when you look at STI-related pathogens that cause PID, the most important will be chlamydia, gonorrhea, mycoplasma genitalium. But in that group, chlamydia is the most important, always underestimated. Now, the secondary non-viral STI that's important is the trichomonas. Why the trichomonas is important? Because usually when you have trichomonas, it coexist and allow another infection or STI. That's the reason why it's an important secondary cause. It doesn't cause alone, but usually allows co-infection. But don't forget other non-STI pathogens that cause PID. Example, secondary opportunistic organisms like bacteroides or E. coli, especially when they are undertreated. And this sometimes occur during procedures, sometimes when you're doing ICD insertion or some other procedures that we do. In the 21st century, the bacterial STI is now becoming less in terms of prevalent, and you see that that's not true. If you look at the WHO publication in recent years, chlamydia still has increased in numbers. But having said that, now the viral STI is much more. Before, the viral STI is much less, but now especially herpes, HPV, hepatitis, HIV. HIV has become lower. I'm not going to talk HIV in this meeting. Now, why is it women are at risk of STI? Now, anatomically, we are at risk. Why is that we are at risk? Because especially younger women, adolescents, the vaginal wall is thin. Even in adults, vaginal wall is still very thin. So it's easier penetration to bacteria, especially when there is some superficial trauma during sexual intercourse. So if there's any compromise at that point, then you can easy penetration of bacteria. And sometimes, in the younger age group, you can have casual sexual activities, one-off. So those, and they're usually unprotected. And if they have infection, it can be unrecognized. And they're likely not to wear condoms. So the risk of STI is much higher, and they are asymptomatic. So the impact of STI pathogens is, so of course it causes ascending infection, upper genital tract infection, causing PID. And that's very important because it's long-term consequences into that. So fertility, ectopic pregnancy, chronic pelvic pain is one of the problems. And pain, why? Because it damages all the organs, it causes adhesion, scarring, and so on. And when you think about malignancy, HPV has a clear association with cervical cancer, and that's one thing that's very important to remember. And of course, maternal-child transmission can happen during delivery. So the pathogenesis of the STI and PID is, of course, we said just now, it's an ascending infection. So cervical function is a barrier. The cervical, the columnar cells produce fluids and it's protected, so it's not easy to get access in the endometrial cavity unless there's a compromise. When is this compromise? During menstrual cycle. When you discharge your menses and the cervical os is open, then you can get a compromise, or during ICD insertion. But we know that ICD insertion, the risk of infection at the most is the most at the first 3 weeks. After that, the risk is much lower. And of course, during sexual activity, because the sperms will need to cross the cervical barrier, and that's again a possible when STI can occur. Now, if there is an ascending infection and you don't treat them, it's unrecognized, it causes inflammation, it causes tissue damage, edema, scarring, and so on, and finally adhesion and tubal ovarian abscess. Now, clinical presentation, you're more familiar with it. One of the common clinical presentation, if they're not asymptomatic, will be vaginal discharge. So sometimes you can diagnose this vaginal discharge. So you see STI sometimes can be diagnosed clinically by looking at the discharge. It's a frothy discharge, like what in the picture is the trichomonas. They can also present with pelvic pain, or inflammatory bleeding, or postpartum bleeding. It's unlikely to present like that. Or they have fever or systemic symptoms, or dyspnea. Dyspnea can be caused also by endometriosis, but it can also cause by PID because of scarring and also because of adhesion. When you look at the findings, examination findings, of course, the local examination findings you'll see in buccal discharge, but cervical motion can also be tender, uterine motion can also be tender, and axial can also be tender due to all the scarring and adhesions. So who are at risk? young people mostly are at risk if you look at the population of the world. Why? Because sexual activity occurs mostly in the young people, they're more casual, less likely to use condom. Female sex worker, client or female sex worker, or transgender, or men who have sex with men. And those who are involved in jobs where they are away from their spouse for a very long time, they are also at risk because of casual sex exposure. And the other one is refugees and HIV positive patients. So when you talk about STI, the spectrum of STI, from girls to adolescent to women to menopause. So how is it like? So in girls, if you have STI, you must rule out sexual abuse, because that's one of the ways they can get STI. So if they're younger than 2 years, you're likely to get sexual abuse. You've got to look at either it's foreign body or something inside that. More than 2 years old, usually they may be from either innocent contact or non-sexual contact, parents, caregivers, and so on. But if you are suspicious, obviously look at sexual abuse. When you look at the population of the world, adolescents makes up about 20% of the world population, and 85% of them in the developing countries. And about 70% of all these problems occurs in adolescents. Why? Because they have early sexual debut. So if you look in Malaysia, previously 20 years ago, sexual debut will be 18, 20 years old. But now sexual debut in Malaysia, depending on which state you're talking about, can be about 12 years old, especially some states in Sarawak can be as that early. And that becomes a risk of STI. Of course, you have multi-sexual partners, can be risk factors, and also, especially young adolescents, sometimes they have challenges in accessing healthcare. They have the symptoms, but because of confidentiality status, they don't access healthcare. So I said the common STI as what we said before. What about elder women? Well, we're still at risk of STI because the sexual activity may be disproportionate, but the men's sexual activity may be different. So they can get STI from the sexual partners, or they have more sexual partners, and then the women are less likely to screen for STI, even currently. I think it's not a practice in our country to do regular screening for STI. And I said just now, anatomically, we are more vulnerable than men. Postmenopausal women, you're not excused from STI. You can get still STI. Age alone does not protect you because of the sexual activity of your partner. But however, when you look at literature, there's positive data looking at STI in the older patient, but you still need to look for STI in this kind of patient if they present with the symptoms we said just now. So when you have a patient coming to you with PID or because we said there's a link, so how do we approach it? Of course, history taking is key, so you still have to take a history. Now, history taking in this, when you take a sexual history taking, it can be very sensitive in our community, but if you are more professional and respectful to the patient, and the patient trusts you, they will tell you the history. So you need to assess patient risk of contracting STI and identify the partners. You must be non-judgmental, establish rapport and trust. And you have to explain why it's needed. And ideally, you should interview them individually, not as a couple. So you take a symptoms, history of the symptoms, the last sexual intercourse, the last date of sexual intercourse, sex of the partner, maybe they have the sex of the partner is male or female, relationship with the partner, long-term, casual, short-term, use of condom. Now, use of condom may not protect you from STI if you do not use it correctly. So condom has to be used consistently and correctly. So you have to identify that also. Sometimes they say they use condom, but they still get STI because they use it incorrectly. Thyroid exposure, orals, vaginal and anal, last previous partner or partner changes within 3 months, and partner symptoms if they know, if sometimes, most of the time they are asymptomatic, or previous history of STI or treatment, and also HIV risk assessment, and previous history of cytology or any other procedures being done, and contraception history. And of course, always assess the risk of pregnancy, because STI, if they have infection, if they get pregnant, there's an increased risk of preterm labor and so on. So what's the approach to diagnosis? Approach to diagnosis is mainly clinical, but you still need to test the STI because it's important for long term and for understanding. So investigation, we do the NAPs, I'll talk about it in a minute, and we also need to do pregnancy tests if you think it's a risk of ectopic pregnancy. Inflammatory markers. What inflammatory markers you do? You can do CRP, but not very sensitive. You can do procalcitonin, more sensitive. Or you can do pentraxin 3, which is not used in our country. Procalcitonin, the advantage is it gives you an idea, it's a severe sepsis, bacterial in origin, then you can start your intravenous antibiotic. But if your procalcitonin is negative, it's unlikely to be bacterial sepsis, something non-bacterial sepsis, then antibiotic will not be useful in that case. So it tells you that way. So that's the inflammatory markers, or you can also do some other fancy ones which is not used in our country. Ultrasound when you suspect to go very abscess or something. And when you interpret this test, negative STI test does not mean there's no PID. And positive test, it just strengthens the causal link. Even though there is no symptoms, then you need to suspect there might be a PID. So principle of management, clinical management, so initiation of antibiotics. If you think it's a bacterial STI, it's easy treated with antibiotics. So you have many antibiotics, either doxycycline, the allergic, they can go to azithromycin, penicillin, and so on. They're all very established. You can look at the CDC guideline on STI, 2021, the current one. So you also need to look at whether or not you need intravenous care, intravenous antibiotic admission and so on, if they're pregnant or if there's an abscess, to clear the abscess. So supportive care, and of course you must have a follow-up. But we also remember a public health strategy. So for those of you who are going to think about the assay, it's important for you to put about public health strategy at the end of your assay. And one of the important approach to management, if you're treating the patient with STI, you must make sure that the abstinence from sexual activity with the partner, and you also need to do a partner contact to treat the partner also, and of course educate them on safer sex and use of condom. Again, I said just now confidentiality, so if you have an STI, you may want to do contact tracing, but you need to ask their permission. Unless you are dealing with HIV, if you're dealing with other STI, they may not give you permission to do contact tracing. But HIV, you are allowed to do contact tracing after you have told them that they have to inform the partner within a certain time frame. If they haven't, then you can do, but not for the other STI. So how do we break this? So this is important to put in your assay. How do you break the cycle? So what would you suggest? So we would suggest routine screening for STI. CDC recommend routine screening yearly for STI under 25 years old. Promotion of sexual health education and safer sex, and the use of condom to protect from STI. Studies have shown that if looking at studying HIV, if the partner is HIV positive and the other partner is HIV negative, they're in a relationship. If they use condom consistently, every time correctly, studies have shown that the negative one remain negative for more than 70 to 80%. So it pays to teach them about use of condom. Of course, prompt treatment we said just now, and of course safe practice. Now I'm just going to run through some of the pathogens. So chlamydia trachomatis, so you know about chlamydia. The many subtypes, serovirus of chlamydia, A, C, D, K, L1, 2, and 3. What's the difference? Now DK are the ones sexually transmitted, genital and neonatal, AC and not. So you only will need to deal with DK. L1, 2, 3, I'll show you in a minute what it is. So these are one of the causes of the STI, which is very important, commonly under the age of 25. And most of the time it can be asymptomatic. And the patient can present without fertility. And if you do the test, you find it's chlamydia. So when you talk about L1, 2, 3 is what we call lymphogranuloma venereum. That is chlamydia trachomatis, but this is presentation is slightly different. They're not associated with PID mainly, but it can present with lymphadenopathy. But why I put it here? Because now in the 21st century, this is also increasing. The trend is increasing globally. So, as I said just now, chlamydia can be asymptomatic. You can only find it when they visit the infertility expert. We did a study before many years ago to find that association of women seeking infertility consult has higher prevalence of chlamydia. So asymptomatic in 80%, they cause cervicitis, urethritis, and they can cause extending infection, PID, pain, and of course dysmenorrhea and so on. So how do you screen? So this is one of the ways to screen. This is the nucleic acid amplification test, one of the commonest tests nowadays we use. It is superior to all the other methods. There are other methods to screen, but that is the most superior, very high sensitivity and high specificity. But it also allows non-invasive sampling. The woman can do themselves and they can bring it to the healthcare provider, more acceptable to patient. And you also can use urine in screening. And it allows a dual detection of CT and NG. What does it mean? CT and CT is chlamydia trachomatis, NG is Neisseria gonorrhea. So this test is packaged together. Usually there's co-infection. So it reports either CT positive or CT negative, NG positive or NG negative. So this is an easy test to do and has a high sensitivity and accuracy. We know that chlamydia complication, PID, chronic pelvic pain is what we said just now. It can also cause Reiter syndrome and Fitzhugh-Curtis syndrome. And in pregnancy, if they happen to get pregnant after that chlamydia infection and PID get pregnant, then they can be at risk of complication in pregnancy like premature delivery, preterm delivery, low birth weight, and so on. HPV, you're familiar with HPV, that's one of the rising viral STI in the 21st century. So there are more than 200 subtypes, and 90% of HPV 6 and 11 will cause genital warts. And so this is important. So there are many types of genital wart, condylomata, acuminectum, verruca vulgaris, and so on. You don't have to know all the subtypes. So you can just mention those in terms of genital wart causing by HPV 6 and 11. But HPV, you know that we can prevent this by vaccination at the moment, and we know that vaccine is very effective in preventing HPV-related disease, and especially the vaccine that contains subtypes 6 and 11. Not all vaccine contains subtypes 6 and 11, only the quadrivalent and the monovalent contain 6 and 11, when of course prevention of cervical cancer. So this is important for you to know. I'm not going to go through how you can diagnose genital wart. Most of the time is a clinical diagnosis rather than a lab diagnosis. So we here just show you that even women and then older age group can still be at risk of STI, can still be at risk of PID because of the sexual habits of their partners and so on. So that's just to show you the vaccine just now. You are familiar with the vaccine, you have a lecture on this. So the other one is herpes, is also important in terms of viral STI. So the one that's important for gynecology will be the HSV type 2. So type 2 causes genital herpes and type 1 causes oral herpes. And they are recurrent, they cause blisters and ulcers, they can cause pain. So treatment will be more of supportive or antiviral. So here, I'm not going to go through the diagnosis of HSV, so you can go through it. So nowadays, either we do a PCR viral culture is not good because it's not the sensitivity. It's very difficult to culture this. So PCR is much better. So trichomoniasis is very important because this is one of the top 2 increase of the STI globally. So it's caused by trichomoniasis vaginalis, but it's very easy to treat. Just like so, and it's very easy to diagnose. You need to send the lab. You can look at the discharge mucoporum, frotted discharge, and it has this fishy smell. So the other one is syphilis and gonorrhea I'm sure you're familiar with it. So on the course of STI, so I'm not going to dwell into it, but just so if you're doing the assay, you're going to go back and think about all this. So in conclusion, STI is a problem globally and also locally in our country. So comprehensive sexual education is very important, and teaching of how to use condoms safely is important. Condom is the only one that can reduce STI. So vaccine, of course, does not reduce STI in general, but condom will use of the other STI that's not vaccine preventable. So increased awareness of safe sex, so viral STI are rising, and we know that we have one of the most effective vaccines currently, HPV vaccine. So I hope all of you have taken the HPV vaccination. Thank you.
Thank you so much, Professor Jamie, for such an interesting and insightful lecture. Any question from the floor? I think everyone is hypoglycemic already, Prof. Hypoxic maybe, HIE maybe. Okay. Since there is no question from the floor, I think the floor would like to give Progeny a round of applause. We'll continue back. We'll have our lunch now. Lunch break, not lunch. Lunch break for 1 hour, and we'll see you guys back at 2 p.m. with another lecture, and then we will continue with our CPC. Slight reminder, don't forget to visit the booth outside, and don't forget to take your lunch to those who pay.